Hello, my name is Marta Alama. I'm one of the general cardiologists and echocardiographers at the University of Washington in Seattle with an special interest in cardio-oncology. And it is my pleasure to present today this very interesting topic, multidisciplinary imaging to evaluate coronary risk in oncology patients, when and how. I have no disclosures. Cardiovascular disease is very prevalent in patients with cancer, but normally when we think about coronary cardiovascular disease in this patient population, we think about heart failure. But the fact is that coronary artery disease is also quite prevalent, and this is due to different factors. First, both diseases, coronary artery disease and cancer, they share risk factors: older age, suboptimal lifestyle, and in general, inflammatory states. But also there are cancer therapies that can increase your risk of myocardial ischemia, and you have a quite comprehensive list of the biggest offenders. And there are studies showing that a diagnosis of cancer with chemotherapy plus minus radiation increases your chances of myocardial ischemia by different mechanisms: vasospasm, endothelial injury, arterial thrombosis, and early atherosclerosis. On top of that, these patients actually have suboptimal care and therefore worse outcomes, mainly because they don't receive revascularization despite it is indicated and there is good data that they benefit cancer patients, or they may be on suboptimal medical therapy for their coronary artery disease. So patients tend to have higher rates of myocardial infarction after debuting with coronary artery disease. They have higher risk of bleeding, potential discontinuation of their cancer therapy, and higher rates of mortality. So it's important, since we are going to all encounter these patients in our clinic, to be familiar with this cancer patient population and try to focus our attention on prevention and early diagnosis. And I would like to start with these two patients from my clinic, Miss K. She's a 63-year-old female who is having this chest pain on exertion concerning for angina. She has metastatic breast cancer, has received many therapies, including radiation to the chest twice in the left, and she has also other classic cardiovascular risk factors. And then we have Mr. R, who is a 46-year-old male with history of ischemia at a very young age, revascularized with normal EF, has T-cell lymphoma, and now he needs clearance for his allogeneic stem cell transplant. And he also has significant amount of cardiovascular risk factors. So how do we approach these kind of patients? Let's start with when do we evaluate with non-invasive techniques for coronary artery disease. Well, if the patient is symptomatic, we do exactly the same as with non-cancer patients. The main difference is that we need to speak with the oncologist and everybody else involved in the care of that patient to see what is the risk of cardiovascular complications versus the potential risk of stopping or delaying important cancer therapy. But other than that, same indications. Other indications in cancer patients: exercise intolerance that persists more than 12 months after the conclusion of cancer therapy. We need to think that maybe this is an angina equivalent. Asymptomatic high-risk cancer survivors, and these are mainly patients who have undergone radiation to the chest. Classically, we offer a screening in patients that have received at least 15 grays of mean heart dose, or a total of 35 grays when the heart is in the radiation field. But nowadays, we also know that older patients with less radiation exposure and more prevalent cardiovascular risk factors are also at higher risk. So we should start screening those patients after 5 years of conclusion of the radiotherapy, and then every 5 to 10 years, depending on their risk profile. And the way to go in these patients is with functional testing. Other indications are more controversial. For example, those asymptomatic patients that are on high-risk cancer therapies, mainly platinum-based agents. Should we test them all or not? We still don't know. How about patients like Mr. R that have significant cardiovascular history or cardiovascular risk factors, and they need clearance for high-risk cancer treatment? Well, here there is no one recommendation that fits all patients. We have to balance the risk of cardiovascular complications with that treatment versus the risk of delaying necessary cancer treatment. So again, multidisciplinary conversation between cardiology, oncologists, and everybody else involved in the care of the patient. And the general rule of thumb is to act similarly to what we do for those patients that require preoperative cardiac evaluation, where we take into account functional status, presence or not of symptoms, cardiovascular risk factors, and how time sensitive that cancer treatment is. And then finally, how about asymptomatic patients that have coronary artery disease in non-cardiac CT? What do we do with those patients? So actually that has been looked at. This group looked at the prognostic value of coronary artery calcifications, or CAC, in patients that are undergoing surveillance oncologic PET CTs. And they compared that value with that of metastatic disease and the classic priming and cardiovascular risk factors. And what they saw is that those patients, in these patients, the highest predictor of all-cause mortality and cardiovascular events are actually metastatic disease and CAC, on top of, independently of the rest of cardiovascular risk factors. Or in other words, those patients who have non-metastatic cancer, CAC is the strongest predictor of all-cause mortality and cardiovascular disease and cardiovascular events. What they also saw very interestingly is that half of those patients will meet a criteria for statin use just based on that PET findings. So we have there a very good opportunity to start prevention measures in patients in order to improve outcomes and decrease cardiovascular events. And what is more important is that that data is there for us to look at. I will encourage you to open your patients' CTs done for other causes to look for vascular calcifications, because you may have an indication for statins there that otherwise will be missed. In terms of stress tests in cancer patients, is there one better than other? And there is very few data. In general, the recommendations are the same that than for patients with that don't have any cancer. And this small study was done in Hodgkin disease patients, and they compared different modalities of stress tests. And what they saw is that nuclear SPECT had the highest sensitivity compared to treadmill stress test and stress echocardiography, mainly exercise echocardiography, but that came at a cost of low specificity or very high rate of false positives, which in this patient population makes a lot of sense because many have received radiation to the chest and these patients have microvascular disease. So they may have perfusion defects with normal epicardial coronary arteries. This will apply for PET as well, right? That can also diagnose microvascular disease. But other than that, we all know the indications and the limitations of the different modalities of stress tests and are exactly the same for patients with cancer. In terms of other techniques, cardiac MRI, we could look for coronary artery lesions, but CT has much better spatial resolution, so we don't use it for that purpose. We are familiar with perfusion cardiac MRI with the use of vasodilators. We can look at worm motion abnormalities and LV function as we do with echocardiogram, and with the use of gadolinium, we can look for first pass perfusion defects during vasodilatory stress, or for late gadolinium enhancement, looking for a scar and viability. No difference between cancer patients and non-cancer patients, but where cardiac MRI may be helpful in this specific population is looking for different patterns of late gadolinium enhancement in patients that come with cardiomyopathy. For example, classic example would be myeloma, multiple myeloma patient with low ejection fraction, and then the reason for that could be either coronary artery disease, and if that's the case with the late gadolinium enhancement, we are going to see subendocardial enhancement. It could also be cardiac amyloidosis, and if that is the case, we are going to see patchy infiltrates that many times affect the atria, or it could be related to the previous cancer treatment with proteasome inhibitors that many times don't even give you any signs of late gadolinium enhancement. There are other cardiac MRI techniques, such as T1 mapping and extracellular volume, that can help us to distinguish myocardial ischemia from other causes of cardiomyopathy. And you have there acute myocardial infarction patient will have a very high T1 and very high extracellular volume pattern. And others, such as, for example, T2 mapping, looking for edema, that can tell us about the amount of myocardial at risk of a scar or microvascular dysfunction that is, as we said before, important in patients who have received radiation, and that sometimes we can miss with gadolinium. Coronary artery calcium, we mentioned before, patients that are asymptomatic who have non-cardiac CTs for other reasons, but how about ordering specific cardiac CTs in these patients, where in the general population, we know that it's a very easy, very reliable, not expensive test. And we know that higher calcium score is associated with higher cardiovascular events. And we also know that the number needed to treat is quite low for those patients who have a CAC above 100. We just need to treat 12 patients with statins to avoid one event. So it's a great example of how medical treatment impacts outcomes significantly. The same applies for cancer patients with just one extra indication. As we said before, please review the oncologic CT scans or any other CT that the patient has had, looking for vascular calcifications, as we may have the indication for statins right there at low cost. We don't have to put the patient under another expensive test. Similar to the general population, in patients with intermediate atherosclerotic cardiovascular risk, when the results will affect management, CAC with cardiac CT is indicated, but also in the low risk ASCVD patient with other non-classic cardiovascular risk factors based on their previous cancer treatment, either radiation or any of the therapies that we mentioned at the very beginning that can also increase your risk of myocardial ischemia. And finally, we have coronary CTA is a great alternative to invasive coronary angiography with really good diagnostic accuracy. It can assess total plaque burden, and it can help us to characterize the plaque composition and tell us about some high risk features that increase the risk of acute coronary syndrome in some patients. In radiotherapy, patients can be helpful, as many times these patients have very eccentric lesions. For example, in that image, you have a patient with breast cancer with a very eccentric, large, diffuse plaque that is not that easy to assess with invasive coronary angiography. So in those patients, coronary CTA can be helpful. Regarding when to use coronary CTA versus stress tests, similar with the general population. If we have a younger patient with very few cardiovascular risk factors where we suspect less obstructive coronary artery disease, coronary CTA probably is favored because it can help us to rule out obstructive coronary artery disease and can help us to diagnose non-obstructive plaque. So we are gonna put a lot of emphasis on prevention measurements. Now, for older patients with higher amount of cardiovascular risk factors, when we suspect more obstructive coronary artery disease, a stress test may be favored because then we can focus our attention on an ischemia-guided management and the amount of myocardial at risk to base our decisions regarding treatment. So let's go back to our patients. Let's start with Mr. R, 46-year-old male, needs a stem cell transplant due to lymphoma, and has a history of ischemia at a very young age with significant amount of cardiovascular risk factors. Well, what do we do with this patient? We pick up the phone, and I found out from oncologists that actually he had a very high risk lymphoma, and he had a very narrow window of opportunity to receive his transplant before the lymphoma recurs. So he had a normal functional capacity. He was on the right therapies to prevent further events. And we decided to clear him for transplant with very close monitoring. And thankfully, he underwent the treatment with no cardiovascular events very successfully. How about Miss K? 63 years old female with metastatic breast cancer on treatment, has received radiation to the chest twice, has significant amount of cardiovascular risk factors, and is having a history that is very consistent with exertional angina. So my suspicion for coronary artery disease is quite high. So I decided to do an exercise echocardiogram. On the top, you have the resting images, and in the bottom, you have the stress images. She was able to go 10 minutes with no symptoms, so that was really good. And in the resting images, you see how she has normal ejection fraction, no wall motion abnormalities. But at peak exercise, she had dilated LV with wall motion abnormalities in different coronary territories, which made us concerned about multivessel coronary artery disease. So we took her to the cath lab, and she in fact had significant proximal to mid RCA lesions and mid left circ lesions and moderate lesions in the mid left LAD. So we stented the RCA and the left circ lesions, and she had resolution of her symptoms. I continue following her regularly, and she's doing quite well, focusing on secondary prevention. So this is the end of my talk. I just want to emphasize some take-home points. First, that coronary artery disease is very prevalent in cancer patients. Patients with non-metastatic cancer and coronary artery disease have worse prognosis than patients without it, independently of other cardiovascular risk factors and independently of their cancer diagnosis. Whereas symptomatic patients should be screened in the same way as non-cancer patients, some high-risk asymptomatic patients with cancer, mainly those who have received radiation to the chest, may benefit from coronary evaluation. The when and how depends on many factors and requires a close collaboration with our oncology colleagues to see how high is the risk of cardiovascular complications, how much we can delay, if we can delay at all, their cancer treatment. And the presence of coronary artery calcifications in non-cardiac CT is associated with increased cardiovascular events, and its identification provides a golden opportunity to start preventive therapies at a very low cost. So as we said before several times, please open those non-cardiac CTs looking for an indication for statins. Thank you very much. I really hope that you are enjoying the conferences and that you found this talk helpful. If you have any questions at all, please don't hesitate to contact me at that address. Thank you very much.